welcome. I'll put you, okay. So, I'm gonna talk about vertigo and dizziness real quick. So, it can be a pretty broad subject. So, first thing is you always want to check for benign paroxysmal positional vertigo, or BPPV, right? So that's the little otoconia coming loose in the ear canal and then causing lots of spinning. That's pretty severe, but also really easy to clear up. So if that's the case, do that, you'll be done in maybe one or two treatments most of the time. So you don't need to waste a lot of time trying to figure out the rest of this. Now, outside of that, this is going to be people that have been dizzy for weeks, months, years, decades sometimes, and nothing works. They've had MRI scans, they've had CTs, they've had blood work. People tell them to put on various medications, and it's not working, of course, because those are like rare exceptions. Dehydration is not typically going to cause vertigo for that long, maybe temporary. And there's a few other things, but it doesn't really matter what they're doing. I guess one of the better things is like a meclizine or something that they're doing, but people generally don't like to be on it because it makes them really drowsy and worn out. And yeah, either way, nobody's really giving them any answers, so here's some good ones. So first thing, you start out over here with the ear, right? My fantastic drawing. So inside the ear, you got the inner ear, so external, middle, and then here's the inner ear with the labyrinth and whatever. So there you've got cranial nerve 8, or the vestibular cochlear nerve. And that's where it all begins, right? And then it's going to come in here to the pontomedullary junction. So you got a little bit of pons, try to make it big so you can see it, and then the medulla will stay here. So then it's going to come right over here. So at this point, there are 4 major nuclei. Organized like that, and there's 4 on each side, of course. Okay, so, and then you've got, we'll just start there. So you've got the superior, medial, lateral, and inferior nuclei. It's pretty straightforward as far as where they go. The superior and the lateral both go up to the cortex, to the thalamus, the ventrolateral pars oralis and caudalis that we have. The lateral nucleus projects there. So we'll get into when that becomes important later. For most people, you're going to stick around here if it's been relatively recent. If it's been like a week, sometimes you just treat this, and that's like all you got to do. Then the longer the time goes, the more it probably is going to be involved. Plus the fact most people are dizzy to some extent already, and they don't think they are. So by the time it gets bad, there's been a few problems, right? Because you're pretty decent at compensating it, and plus most people aren't pushing themselves enough to notice that they're unsteady when they spin or they rotate or they change positions quickly. It's like, hey, I can't get out of my chair anymore. When I sit up out of bed or something, it gets really bad. At that point, yeah, it's pretty advanced for, I guess you could say. So the medial and the lateral go down the spinal cord and become the medial vestibulospinal tract and the lateral vestibulospinal tract. The lateral vestibulospinal tract is going to go lower to the extremities. The medial is going to be controlling head and neck movement with like postural adjustments as well. So that's going to go all the way down to bottom of thoracic cord area. So you'll get pretty big response with both. We like to use the medial vestibulospinal tract for headaches and all sorts of stuff. Like it really is pretty cool. So that's making adjustments based on, you turn your head, you move your eyes, you rotate. You have to make adjustments so you don't fall over or tip over. and also so like you're ready to take off, right? You do something like this. If I haven't shifted my position at all and I try to run, I'm going to be like going this way, not precise, and really don't have any sort of ability at that point. So that's really important. And the lateral vestibular spinal tract go down to the feet even. That one does a pretty good job with calves that are a little difficult to work with. They aren't really coming back as much on their own, but that does a pretty good job bringing them back. So that's going to give you a lot of that just kind of postural motor control stuff, mostly extensors. But you don't get effective control of those things unless you get good input up higher. So those are feeding there. Now there's 4 more little nuclei. We still like to refer to them that way. You've got, we'll just draw them over here for sake of visual. You've got the Y group, the intercalated, the parasolitary, Y group, intercalated, parasolitary. Yeah, that's what I can remember at the moment. So these guys are a little smaller, but they have just as big of roles. So the parasolitary is going to be similar to the inferior nucleus in its function, as far as they are giving your brain the position sense for changing of postures and exercise. So you got, when you lay down and you stand up, your blood pressure changes rather rapidly. If it doesn't, then you get really lightheaded. You get that postural hypotension or orthostatic hypotension. And some people get the syncope, right, and they just totally pass out. So these two are very involved with that. Of course, cranial nerve 8 is as well, but a little less specific to that, but it still has a role, obviously, because that's where everything begins. So these two do that. They also join in with the vestigial nucleus in the cerebellum, which is going to be Sentinel info over here. So we'll just say the vestigial nucleus. And there's a particular division of that called the vestibular division that is going to, and the rostral division will also have some of an effect on it as well, but the vestibular is going to be more so. Now, everybody knows the cerebellum has lots of input proprioceptively, right, from all the muscles, and that's kind of how you execute all your basic motor functions, right? All the stuff you've kind of learned already between that and the inferior olive. So, is there a cerebellospinal tract? Not really. So what it does is it comes out in a couple of ways, but the vestigial nucleus comes over here to the vestibular nuclei, and that gets its input through the vestibulospinal tract. So a lot of that, again, extensor tone and control is coming from the cerebellum, but it does throw through the vestibulospinal tracts. So then this is another input for that baroreceptor reflex in the changing of positions and on changing respiratory and heart rate and blood pressure with response to exercise and other physical activities and demands. So all 3 of those are going to have an effect on that. Just to continue on this same vein, so that we remember kind of what else we can do, is that from here it goes over from these nuclei and it comes to solitary nucleus, or the nucleus tractus solitarius, or whatever you want to refer to it as. And that's nucleus crosses midline, pretty big, and most of your visceral functions, like all of them, are going to come through there at some point. So, but particularly we got a couple of divisions. You got the baroreceptor division, so most definitely going to have a close tie to that one. And then you've got the carotid bodies, or chemosensory ones. So those are going to be a little less responsive, but so primarily with this reflex, it's the baroreflex division, or baroreceptor division. And then from there, it's shooting over to coordination with the aerial postrema and the rostroventrolateral medulla to actually execute the function of increasing the heart rate and blood pressure. Now, one other thing to kind of be aware of is the parabrachial nucleus. So, I mean, this is kind of extended once you've had difficulties. So sometimes, I'd say most of the time, you're going to get taken care of with these two, maybe some of this one. And if this isn't enough, you're hitting that baroreceptor division, the solitary nucleus. That's still not doing it, and they're still getting dizzy. The parabrachial nucleus is around the superior cerebellar peduncle. There's a group of them, but there is the external lateral division. Group. There's several divisions there, and there's 3 of them there that are going to affect the baroreflex sensitivity. So 2 will increase it, 1 will decrease it. You might ask, why would you want to decrease the baroreflex sensitivity? And that's, think, when you get a pounding headache, right? Just an overreactive response to something like that. So that's the serotonergic division. And then you've got a couple others that are going to be sensitive to fluid balance and so forth. And also responsible for coronary vasoconstriction. So it's pretty important for a few things, but for this, typically increasing the sensitivity is going to be what will get the job done. So the divisions there's a paraventricular division of the hypothalamus, and there is an areopostrema division. So those guys are all kind of coming together, and then we'll get to the rostroventrolateral medulla. Eventually, we don't have it yet, as of January 30th, 2023. So this is where we are at the moment. Lots of options. So that's the baroreflex division portion, and the postural changing portion of the dizziness. And you've got the intercalated nucleus, which is primarily the vestibulo-ocular reflex. So that's going to be like your head impulse test. You have them focus on an object, you take their head and you jerk it from side to side, and they need to stay focused. If they can't stay focused, or sometimes you'll see their head turn and their eyes just shoot in that direction. You're like, whoa, that's obviously not normal. You need to be able to stay focused on target when you turn your head, right? Like if you're driving, or like right now I'm looking at you on the camera, but I'm turning my head, I wouldn't be able to do that, or at least not well, or it'd make you dizzy. So another way you can test it is you can stick your finger out or an object and have them shake their head, see if they can stay focused on it. Sometimes it's kind of hard because their head's moving, but just ask them. So usually it's like, yeah, that wasn't very fun, or makes me dizzy, or their head will do things like this. It won't stay level, so it should stay pretty straightforward, horizontal. And then if that's not enough, you can start making it more difficult. So you can hold it there, start moving the finger in different directions, and they'll start and do either stop and won't be able to continue movement when that begins moving, or it'll make their symptoms worse. You don't need to do this if they already get sick just holding still, so that's obviously more advanced, right? When you're trying to tease out those last little things. So at the beginning it's pretty easy. Everyone's got some little quirk in the process of trying to get rid of their vertigo if it's been there for a while. So just be prepared to dig a little deeper, okay? So this is digging deeper. So if that's still a problem, then you need to keep looking into that vestibular dysfunction. Said intercalated is that's its primary job. Doesn't mean it's the only one that does it though. And it can also have influences on the apokinetic reflex and so forth. But biggest influence on the VOR. So there's that. Anyway, so you begin moving it, and you can go up and down, side to side. Don't go too fast, obviously, because they're just shaking their head. So just kind of, side to side like that. And you'll see that they'll just start turning their head weird, or they won't be able to continue to follow, or it'll just make them real sick. So, and then it can become even more subtle depending on the person. So you just need to pay attention, but do it, you'll see it, you'll figure it out as you practice it, okay? Next, Y group is pretty cool. So that's head and eye velocity signals. So it's gonna be the quick head and eye movement. And so if you're like, for some people it's just driving, so doing the head check and bringing their head back, just moving the eyes and the head back quickly, enough to really make them dizzy. But if you test it like that, you're gonna get few different things. So the test I typically do is I say, hey, follow my finger. Typically when you're doing eye movements, you tell them not to move their head. This time I tell them to. So move your head and your eyes and follow my finger. And you need to cover bigger ground, right? You're coming much further, and they should follow. Now, if it's functioning correctly, they'll follow with their head and their eyes pretty coordinated. It'll be a coordinated movement. So the eyes will move and the head will move and whatnot. And they'll be able to look a little further than just neutral too. So if they only move their head and their eyes stay pretty much in the same position, it's probably a problem. And if their eyes move really far and their head maybe moves sometimes, also a problem. Or if they're just really separate. So they'll move their eyes, then they'll move their head, then they'll move their eyes, then they'll move their head. It should be a rather smooth function. The more segmented it is, the more likely you need to treat it. And that goes, and you also just check obviously the regular testing method that we use. So there are those. The medial vestibular nucleus, this one right here, is going to have a similar function to something called the nucleus prepositus hypoglossus, which is also like right here. The interesting thing is it doesn't actually communicate with the vestibular nucleus at all. This one's a little more rare to treat, but still actually more common than you might think. So they both do horizontal gaze and head rotation. So if you're having a lot of issues there, those two are your go-tos. The medial nucleus, medial vestibular nucleus is also a head rotation and postural coordination, right? So this test for the medial vestibular nucleus is about the same as the medial vestibulospinal tract. So what I'll have them do you don't really test this unless they're passing Romberg and maybe even single leg balance, right? If you stand on do Romberg and they're all over, but you don't go this far because then you'll just be falling, okay? So anytime you test these, you need to be close by, arms around the person, not necessarily touching them, but prepared to help them give that balance so they don't fall and even catch them potentially depending on how bad they are. So make sure you're there for them, never leave them alone when you're testing these things. So what I would do for that is you start even with just eyes open. If they're really dizzy, keep them both feet on the ground but touching, so like as if you're in a Romberg position, and then just have them look in different directions around the room. Doesn't really matter what order, you can kind of stress it. So sometimes it's one direction that's a bigger deal, sometimes it's the full rotation that throws them off. Do something like this and they'll do that. Or maybe it's an up and down thing. If it's up and down, these will help, but there's probably a little bit more to it than just these two. Now, if that's not bad, put them on one leg and then you do the same thing. Right? Up, down, left, right. You can even come back to the middle, back again. If you got a big space, sometimes I'll stand there, have them do it, and I'll have them just follow me, and I'll go different depths. I'll go side to side, I'll change directions or whatever, and they just kind of follow me. But either way, they won't be able to control their head and their eye movement with their balance at the same time. So if that's the case, you're treating one of these two. The nucleus prepositus hypoglossus, kind of more just horizontal gaze. And they'll have maybe a little bit of an effect on these other things, but not really, again, because it doesn't communicate with the vestibulospinal tracts or anything else. At least not that I've read about, and they pretty distinct to say that it doesn't. So, next, the superior and the lateral are projecting up to the cortex. So, it's kind of your conscious awareness of where things are. So there's those ventrolateral pars, caudalis, and oralis, portions of the thalamus. And to test those, you might think this is a little weird. I thought it was kind of weird, but it works. Have them stand in a Romberg position as well. And this is kind of that conscious connection to balance, right? So most everything is kind of reflexive for the vestibular system itself. So you're having them kind of react and make sure they can maintain balance. Now we're trying to separate the two, but still maintain balance. So in this case, you want to keep the head stationary and the eyes focused on an object and have them move their body. So if they're able to do that and maintain balance, we have a good communication to the thalamus. If not, and you treat one of those two. Again, this one's kind of later. Not as often do you need to treat this, but here it is. So here's the test. So I'd have them just stay focused and then have them twist their body from side to side. And they'll be they won't be able to do it. They won't be able to keep balance, and which is interesting because their head's not really moving much, right? So that one seems to be a pretty effective test for that. Probably get a few laughs and some looks, probably like you just did, because it is a little different, but I mean that's what we're looking for. So there's that. Now remember that each vestibular system pushes in the opposite direction. This is the push. Okay, so if you've got an overreactive or a dysfunctioning left side, you're going to be falling right, and vice versa. And I'd say typically in these situations, you're going to have them bilateral problems, so you're still treating them bilaterally because they're going to be falling all over the place. But it's not always that way. And in that case, it actually seems to be a less severe overall in appearance when you test them when it's only a one-side problem. But be aware of that. So if you need to just treat one side, just treat one side. Make sure you're figuring that out as you're testing and treating. Now, you've got a vestibular commissure. So these guys have a nice little band communicating to one another. So everything we're talking downstream, upstream, but they definitely need to tell each other what's going on, because if you're getting in one overactive, the other side is just going crazy. So if you have balance problems on both sides, maybe one side's a little bit extra, it doesn't mean it's a one-sided problem per se. It could just be that they're not communicating well enough with each other. So this one's been pretty big for like a single leg balance and whatnot, and but you'll get one that just starts to go and you just can't stop it. So you have this, and cool, that's the other thing to say. The vestibular commissure is mostly inhibitory, so that means something's overactive, it's just not getting the signal to say, hey, calm down, dude, like it's okay. So that's what it is. When you get one quick head movement or something like that, or when you're on one leg and there's just a small input and it's like taking off, that's probably what the need is. Now, that's the main vestibular focused problem. Now, it gets a lot more complicated sometimes. So first off, if you get someone who comes in with a tremor, especially a head tremor, it's going to be a lot harder. Okay, so don't tell them that they'll be done in a couple of visits. It probably won't happen. Because if you think about it, you can improve a ton, right? But it's not going to be totally gone as long as their head's shaking like this and they have a really insensitive vestibular system, or the vestibular system can be too sensitive because their head's always moving. So at that point, you got to really work your eye movements and just the motor control side of things. Otherwise, you're going to have a lot of problems. Those are the ones that I've had the hardest time with, but still been successful. So you just be aware that's going to be the case. So I have one lady who's in her 70s, right? Has been dizzy for a long time, but she's never been able to do a lot of basic things like skipping. She doesn't have peripheral vision outside of here. Head tremor, her hands are shaking and everything. But she didn't have control of the trunk either, right? So if she were to stand and her body began to move, then it would just start going crazy. So it was this massive imbalance from side to side. There's just no smooth control. So it's like it goes to reflexive movement right away, as in a tremor, right? So it's like you have oscillated movement and not really any inhibition from the cortex. So you just get this spinal like whoop, loop. Things go back and back and forth and forth, back and forth. They just keep going. Okay. And there's a couple different kinds of tremors, of course. Essential tremor seems to be a little bit of both, resting and intention. But either way, especially in the head, either way though, that's going to need to be addressed if you want to help them fully. I'll probably go into tremor more in a different video, just for the sake of not making this one too long. So if that is the case, go watch that video and I'll give you some more specifics on what exactly is happening and how you can affect it. Next thing is eye movements. These eye movements and the vestibular system are not, you cannot separate them. So they are very much together in all that they do. So probably one of the bigger portions of what you're looking at is the superior colliculus. Here, there's several divisions of that. So one, you could have a problem, they can't fixate it on an object, so anytime they're looking around, it's like things are moving. You know, it could be reading, it could be just looking off in the distance. They just can't stay focused on one thing, so their eyes are just kind of bouncing around a little bit. Then you need to treat that one. I think it's the straight amalgam intermediate. Is probably the biggest one for that. Stratum's anal is like almost everything, so that one's just kind of a good overall. If you need to cover a lot of bases pretty quick or you don't know where to start, that one's likely to be involved. And one other one in there is involved in fixation too. And then you've got others, it's just a quick movement, right? So you need to be testing saccades, both reactive and volitional. So volitional would be like they actively look between two different targets. So I would do that with my fingers again, or pens or something, and I'd just say, okay, look at this one, and then I tell them look at this one, and I'll just move them around from one to the other. And if you want to see if they have cortical inhibition or ability to just kind of stop it, you tell them not to look until you say go. And sometimes you can bring one finger by the other one, and they'll just follow, and they won't be able to stop it. So in cases like that, you're looking at more ADHD type stuff, but it can still be involved with this. But there's another way to test the volitional versus reactive. Reactive, you just kind of have them watch your finger and go fast, pretty much any pattern or direction that you want, and that makes people dizzy all the time. So that one's gonna be involved probably most of the time as well. Yeah, once they get going, one, they'll just lose it. Like you'll be following and they'll be like, whoop, and they'll have to like find it. But they can be close enough to just seem a little bit behind, maybe really choppy or really saccadic. In those cases, they're still gonna need it, and they'll always ask, because they'll tell you that I didn't really like that was really hard, or that made me a little dizzy. So you need to address those as well. So that's the superior colliculus thing. You've got frontal eye fields are involved, so like cingulum frontal eye fields would be one. Pulvinar thalamus is a big one for saccades. Another thing for the pulvinar thalamus is its function is when you're moving or changing between targets, you got a whole bunch of other things around, right? Whether you're driving or not, other things are in motion, but you need to be able to tell the difference between your motion, these two objects that you're focusing on, and then your surroundings. So if you can't do that and you've learned the lines, you're gonna feel really dizzy. Depth perception might seem a little bit off. It's not particularly a depth perception thing, but you just have a hard time discriminating between what you're trying to look at and everything, the motion of everything else. It's just moving your eyes. It should not feel like the world is moving when you're switching targets, but to them it will. So one way you can test that is have two objects. I even just put them like in my hands, pen on either side. I'll have them again stand kind of in a round position, or maybe on a single leg if they're further along in their care. Stand on one leg. Again, if they can handle it. If they can't stand on one leg and then you're trying to test pulvinar and they can't keep their balance, obviously it could be something else because they still can't balance on one leg. If they can, and it's not really a problem, then challenging something that may not be as big of a problem originally will become more apparent, right? So if you're trying to tease out these little things, push them to the edge of what they're comfortable in doing. If you're trying to do it and they're in a Romberg position, but they're excellent, their balance is pretty good on single leg, you're not even going to see the problem because they can make up for it, right? So you want to push them to that edge of their ability and then test something extra. So in that case, stand them on one, have them look at two things. While they're there, you tell them to switch between targets, and then I'll just like move my hand in different directions, and you'll see them kind of sway a little bit, or they'll have a little bit of the symptomatology that they had to begin with. In that case, treat one of the pulvinars. There's 4 of them. Figure out which one. That's not the hard part. So, other than that, optokinetic reflex can be something that'll make people dizzy. Again, that's as a passenger in the car is kind of like the textbook version of when you need it. But reading, that'll make you dizzy. Or if they just can't even read because it gives them a headache or something, optokinetic reflex. Dizziness will usually be accompanied with it. That one is really complicated. So you're looking at, again, vestibular system, superior colliculus, but almost any subcortical fiber could play a role in it. So that one you're just going to have to kind of test through, use your head. And it depends on the position too. So if you're doing the optokinetic reflex, which is slow, smooth pursuit followed by nystagmus, corrective nystagmus, right? And then, not corrective, sorry, just a nystagmus, and then a slow, smooth pursuit again, and another nystagmus, okay? So I'll test that just with my finger. You can go in any direction, really, but just kind of move quick, go fast. Pick different positions too, so that they're not just guessing. So if they're decent at guessing, they can fool you if you're doing it exact same every single time. So I'd go all the way to this side of the vision. Sometimes you cross midline, sometimes it's on the other side, and you'll notice there's a difference actually between positions. That'll also tell you something else. If it's vertical, you're looking more at rostral interstitial nucleus, which is a good point to bring up. So all of the vestibular nuclei and the cranial nerves communicate one with another via the medial longitudinal fasciculus. Okay, so that's coming up and down, and that is very important for coordinated eye movement, and probably an absolute necessity to have treated in most people that have had vertigo for more than a month or a couple months. Right? So pay attention to that one too. Then you obviously get the cranial nerve 3, 6, and 4, mostly 3 and 6, but 4 will still do it, for dizziness as well. And sometimes that'll be off on one side. So I've got one of those late, like right now. So if you kind of go off to the side at extremes, and maybe even kind of come in and out a couple of times and see if they can actually hold it. If they can't, you've got a problem with like abducens nerve off to the edge, right? So if that's the case, you need to treat that, because just the whole looking to the side thing, they can't do it quick enough, or they can't maintain that, and that'll throw off just enough that I give them some feelings of dizziness. And it doesn't always make people dizzy, but it can give them headaches and stuff. So that is something to be aware of as well. But I mean, again, if you're turning your head and then they're looking and then they're having problems, that'll do it. Another patient, just teasing out little things still. So I'll have him look at my finger, because like DOR doesn't do anything. If he's over here at the end range and then he turns his head just a little bit, so you can still see his finger, but it just takes it right to the end. That makes him dizzy, or it made him dizzy. So that would be like a abducens nerve problem, cranial nerve 6. 3, sort of a vergence thing. Most eye movements obviously are involved with cranial nerve 3, oculomotor nerve. So pay attention to those. Oculomotor nucleus is going to be most involved with the vergence portion, looking in and out. So look at that too. Now, if they're not working together, so you can even test one eye open, one eye closed. I had to do that lately too. Just like head motion, or like she's doing like head checks was a problem. So if she were to look over and back, and it was more so with eye movement than head movement, made her dizzy, then you're looking at more cranial nerves and eye movement stuff, right? Then we treated that, and I had her close one eye because it was just a one-sided problem, because the other side was totally fine. So it was, she'd look with the eye closed that had the problem, and there was no dizziness even with the head rotation. And then if you were to put it back in or close the other eye, then it became a problem again. So then I just treated the oculomotor nerve, and then that went away. And then we had, move on to the next thing, right? Which was more of a head movement thing at that point. But things to pay attention to. And if they're just not coordinating together, you can kind of see it. Their eyes might just be a little different. Or if they have like strabismus or something, where their eyes don't work together, you're going to have to go through pretty much all the cranial nerves, potentially some muscles, probably several muscles, to get them to work right. But strabismus doesn't also equal dizziness either. Some people are not dizzy at all and they've got it. But if you got both, you might need to do a little bit of both. So there's cranial nerve things, and the ascending medial longitudinal fasciculus is going to do more for that eye movement than the descending portion. And that rostral interstitial nucleus is located within the MLF. So those go together. And the rostral interstitial nucleus is in charge of vertical gaze. So optokinetic reflex, vertical gaze, head up and down, those are all that function. And almost fairly isolated there, so that makes that part kind of easy. So make sure you use that. And it's also involved with some of this like circular motion, okay? Yeah, because it's coordination of the abducens nerve too. So again, it's still within the MLF, so pay attention to those too. If you take care of vertical gaze, you'll probably catch it still, but there's an option. Quick thought back to pulvinar. So I guess another example would be when someone's like driving, right, after a car accident or concussion or something, and like the windshield wipers are on, or it's raining or snowing, and it's like making them real dizzy, or giving them a headache. Think pulvinar again, because that's things motion. They're trying to focus further down the road, but stuff's going on in between the two, and they can't do that. There you go. That's like that motion canceling effect that your brain should be able to do, but it's just not. So there's another input there. Yeah, that would be most of it. It's not an all-inclusive thing. Sometimes it's a visual acuity thing. Sometimes the dizziness is involved with the gut, you know. It's that's, again, that one's pretty rare. But I mean, you're gonna have to be a little flexible, okay? This will take you most of the way for most people. And it'll even be emotional sometimes. If it's an emotional problem, it could be because of overbreathing, okay? And that would be like a parabrachial nucleus issue, mostly. At least that's where we look at the moment. Because they're a little anxious, a little whatever, they're hyperventilating, and that'll make them a little lightheaded. So that's why like meditative breathing or something could be helpful in circumstances like that. So you can even just have them do some breath holds and whatnot, try to get the respiratory rate down, and then see how they do. And if that changes it, then probably treat something for the anxiety, panic or whatever that they may be experiencing on a regular basis. Or and the parabrachial nucleus is a big part of that, not the only part of it. So just pay attention to those. There's like the limbic nucleus in the limbic solitary nucleus that connects to the amygdala, which gives you like initiates that panic response based on how cardiovascular system is feeling. So you might have to look at that. We'll go into more of those things again later. These are just potentials that might show up if you're getting a little frustrated. They could be a piece, right? So you just need to kind of figure through that. But this stuff will get you 80-90% of the way most of the time. Or it should take care of like 80-90% of cases. And then in the other cases, it'll take you pretty close to being done. You might have a little bit left over. You got to do a little more. The vermis is very important as well, because that's going to control your upright posture. The nodulus is probably one, because it's involved with the flocculonodular lobe, which is like your vestibular cerebellum, right? So that's going to be a part of it too. And that's kind of like a more of a motor control thing as well. Yeah, so those are involved. That'll kind of take care of it. The other thing, I guess, with the optokinetic reflex, there's the medial temporal lobe division of the cingulum. And that's going to be if you're doing the optokinetic reflex, and when you do the quick beat, right, the nystagmus, then you start going slow again, and they have a hard time transitioning right there, you treat that. There's various other things that are going to control the different portions of it. So if you're having issues with the smooth pursuit portion of the optokinetic reflex, you're looking at the superior colliculus, probably the superficial or intermediate gray layers that go to the cerebellum and the basal ganglia, right, for smooth movement, and so forth. So I'll go over eye movements more specifically later as well. But here's your dizziness, vestibular dysfunctions for the most part. Let me know if you have any questions or if you want me to re-explain anything, and I'll do that. Alrighty.